I am Valentin Fuster from New York. Welcome to the European Heart Journal today. And we are in Barcelona, the town where I was born. So I feel very comfortable. And I also feel comfortable because I'm dealing with a great friend, Dr. Lars Valentin, Professor Lars Valentin from Uppsala in Sweden, who is going to talk to us about the trial that is presenting at this meeting, the Stability trial. Lars, nice meeting you in my town.
Thank you. Thank you.
Tell us a few words about the Stability.
Well, the Stability trial was for the first time testing a concept of an inflammatory inhibitor in patients with chronic coronary artery disease. And in Stability we are testing the LPPLA2 inhibitor Darapladib versus placebo. And patients that were included were patients with stable coronary artery disease, previous MI, or evidence of coronary artery lesions, and they needed to have an additional risk factor. And they were also treated with optimal medical treatment. So 90% of the people were, or even more, 95% on statins. The ACE inhibitors around 80%, beta blockers the same, also very intense diabetes treatment in patients with diabetes. So it was really to evaluate, does inhibition of inflammation add to the effects of other medications? We exposed the patients to this for a median of 3.7 years, so around between 2 up to 5 years. The primary results were presented at the ACC meeting in March and published in New England Journal of Medicine. And the primary results showed that we did not reach our primary target to significantly reduce cardiovascular death, MI, and stroke. There was, though, an effect on the secondary outcome, which was major coronary artery events, that is coronary heart disease, death, MI, and urgent revascularization. So what we present at this meeting are results in relation to the LPPLA2 levels in plasma, which we measured now retrospectively. And of course the hypothesis is that Darapladib should have a more pronounced effect in patients with high LPPLA2 level.
It is my understanding, is that right, that there are a number of studies that actually showed that the LPPLA2 is related to mortality, stroke, and so forth. A number of studies in the past, but
yes,
not.
I could come back to that because we then measured the LPPLA2 level and whether there was a relation to a treatment effect. So in this presentation we verify very much that there is a relationship between LPPLA2 level in plasma.
And this is the largest study.
It's the largest study. It's 16,000 patients. So it was definitely verified. There is a relationship to myocardial infarction. There is also a relationship to stroke. So therefore the epidemiology was very much verified in the trial. We also showed that the Darapladib treatment really lowered, as expected, the LPPLA2 level by 65% continuously during the whole period of treatment.
But what happened with the
events?
events?
What happened with the events? Well, I mean, we had the major trial outcome. We had only a slight reduction, not significant. And in relation to LPPLA2 level, unfortunately, there was no significant interaction. So therefore, there was a similar reduction in relation to totals of LPPLA2 level. There was kind of a trend to a larger effect at higher levels, but still no significant interaction. So our conclusion must be that unfortunately measurements of LPPLA2 level cannot identify a specific response to the treatment, and overall we only have this slight reduction in major coronary events.
Well, I think your study, frankly, is probably more important than what you think. And let me present to you my view of it. You drop the LPPLA2 and nothing happened. On the other hand, the level of this biomarker relates to events. How this is possible? And if you look at your data on statins, for example, it's quite interesting because statins are anti-inflammatory drugs and they drop the level. So my hypothesis that I'm presenting to you is probably this is a marker of inflammation, and if you block the marker, nothing happens. But if you block the inflammation, it might.
Yeah, I mean, obviously we only have measured an indicator and only one component of the inflammatory cascade, really. And we know that, as you indicate, that the levels of LPPLA2 are related to the LDL level. So therefore, we could see that in patients with low versus high LDL level, there was a substantially lower LPPLA2 level, and the statin treatment would have already influenced the LPPLA2 level.
I think this is fascinating because in a way what you're saying is to measure the level in patients, for example, could be quite meaningful, thinking that this is a manifestation of an active process, but certainly we have to block the process.
Yeah, and it might be that we also believe, as you say, that this might be a useful risk indicator for an ongoing atherosclerotic inflammatory process, but it might not be the key mechanism we should try to influence in order to stop the process.
In other words, it's a product, the molecule is a product, but it's not an active product that may cause the disease, but it's a biomarker.
Or it might also be that at this stage of the process, which is fairly late, this mechanism might not be as important. So we have fairly advanced disease with patients already having had a myocardial infarction. Maybe this is a process because we have experimental evidence that it really has an impact on experimental atherosclerosis, but maybe we are now at a late stage where other mechanisms are more important than the LPPLA2 mechanism.
Well, this is one of the best designed studies that I have seen in a large population. I read it very carefully, and I think you have to be congratulated. And actually, the co-authors of your study are very well recognized. You know, Harvey White, I believe Chris Cannon, Steph from Paris.
Great friends, all of them.
Great friends. But what are you going now? You know this data, it's very solid, very well designed. What is next? What do you plan to do with it?
Just now we are really digesting into the data. As always when we are doing trials, we have a kind of an abundance of biomarkers. So we are trying to understand, could we influence the disease process in some subgroups to better understand whether there is really a place where the LPPLA2 mechanism influences the disease. So that's one part of it. We are even exploring the genetics, but as you know, there is another LPPLA2 trial presented at this meeting in patients with acute coronary syndrome.
Yeah, I know. Yeah.
So and these results are known, they were also neutral. So we think that the LPPLA2 mechanism might be most influential in the early stages of development of atherosclerosis, and the LPPLA2 plasma level could indicate the activity of that process. That's how far it can come.
Is any relationship between this biomarker and CRP?
There is a certain relationship, but they are not that closely related. So both of them are independent prognostic indicators.
Which may come from the same source.
Yeah. But both of them are independently related to outcome, and both of them contribute. So,
in summary, for all of you who listen to us, important biomarker, the LPPLA2, who really is a biomarker of events, cardiovascular events, but if we block this biomarker specifically, it drops with the drug that was discussed, but it doesn't really has anything to do with events. And the question is this a product of an inflammatory process? And that's where we have to aim our goals in primary prevention perhaps, or there's something else. Thank you very much, Lars.
Thank you.